Good evening, everybody, and welcome to tonight's webinar. So happy to have you along today. My name is Kay, and I am part of the team here at Musculoskeletal Health Australia. Before we begin, on behalf of Musculoskeletal Health Australia, we would like to acknowledge the traditional owners of the lands from which we're broadcasting today and pay our respects to all elders. Just some brief housekeeping before we get started. A recording of the webinar will be made available so that you can rewatch it on demand. And we will also have some time for some Q&A at the end of the presentation. So please feel free to send through any questions that you might have as we go along. So tonight's presentation is designed to give us a greater understanding of the autoimmune condition Sjogren's disease. Hopefully I've said that correctly. And what it is, how it is diagnosed, and very importantly, how it is managed. Our presenter tonight is Associate Professor Alberta Hoi, who is a rheumatologist and leading expert in translational research in Australia. She is the head of the Lupus Plus Clinical Research Hub at the School of Clinical Sciences at Monash University and the head of the Monash Lupus Clinic, as well as being involved in a number of investigator-initiated studies and clinical trials. So we're very grateful to have Alberta tonight presenting on this topic for us. And so on that note, thank you again, and over to you.
Thank you, Kay. Let me just share my slides. Okay. It's been a little while since I've done one of these. I have done a couple on SLE, but I'd like to actually cover the topic of Sjogren's because it's actually quite a timely presentations about these conditions. It's been sort of a bit neglected in many ways, and I hope I can explain to you what the state of the art's development in this disease, and to perhaps explain that this is more than just dryness or sicca. So I too want to acknowledge the traditional owner of the land, and if there's any elders present in this presentation, I'd like to pay my respect to them and all the past and present and emerging leaders as well. So, what is Sjogren's disease? It is a chronic multi-system autoimmune conditions. I think many of you on the audience might see different types of autoimmune disease and understand the concept of that. Most people would know about our immune system in its normal functional state is there to protect you against pathogens, so bacteria and viruses and so on. That's its primary role, but sometimes the immune system can become a bit confused and start to attack your own body. And we call that an autoimmune process. Now, depending on which organ it attacks and different pattern of that can emerge over time, we give different names to these clinical conditions. So Sjogren's disease is really one of the most common autoimmune disease known. And if you do a little Google search, you'll find that there are many examples of common autoimmune disease. Perhaps the most well-known is lupus, where it affects mostly women of childbearing age. It's certainly multi-organ like it is with Sjogren's. Rheumatoid arthritis, you will hear a lot of people discussing, and that's quite common in the community, about 1% of our populations. And then some of the skin condition, for example, psoriasis is a autoimmune conditions, and about 30% of the people with psoriasis can develop arthritis, and we call that psoriatic arthritis. And so these are all the common autoimmune conditions that we see in our community. So there are probably a fair bit of information on Sjogren's disease on the internet. Most people think of Sjogren's disease as an autoimmune condition that affects only the moisture producing glands. And I found this little video clip on YouTube that sort of explained about the difference between Sjogren syndrome versus just dryness syndromes or Sika syndrome. I find that this issue is reasonably useful because Sjogren syndrome is probably more than just the dryness aspect that it can affect people. So who's affected? Similar to lupus, it has a very high female to male ratio. So most of the patient affected are women between sort of age 40 to 60s. It is among one of those many autoimmune conditions I mentioned before, and often in the nomenclature we talk about primary versus secondary Sjogren's. And that's sort of when the patient get assessed and we see whether there's any other linked autoimmune conditions. Now, in the past, Sjogren's is often seen with lupus, and so the term secondary Sjogren's is often used. It can also be seen in people with rheumatoid arthritis, but sometimes this type of nomenclature is sort of getting a bit old-fashioned because we sort of feel like that there really isn't a dominant, there's not a hierarchy of disease that if you have Sjogren's problem, then it really doesn't matter whether you've got primary or secondary conditions. So I think we'll increasingly see this term phasing out. So in terms of the symptoms and impact of Sjogren's disease, the most common symptom, as I said, people tend to associate that with the dryness, so dry eyes and dry mouth. But with dry eyes, sometimes people don't sort of maybe articulate it in the same way. So some people would use the word dry. Sometimes people might describe it as a sort of gritty sensations. It can also sometimes when the corneal surface is so dry that it can be a bit irritated, and so you can get burning sensations, or sometimes it can overcompensate and get irritations and have excessive tears in some instance. The other common complaint is people talk about inability to focus and getting some specific eye fatigue, especially when you use, read or use computer screen for a long time. And with dry mouth, also, sometimes people, again, may not articulate the word dry mouth. They might just talk about their problem when they eat, perhaps either difficulty in swallowing drier or chunkier food. And the other common problem patients get is dental issues. And they may, because of the lack of saliva, you actually have an accelerated damage to the enamel, and so you get dental caries and so on. Now, the other most common symptoms are relatively non-specific to Sjogren's. So we see that in a lot of other autoimmune conditions. These are the joint pain, muscle pain, and fatigue. The joint pain sometimes can also manifest as more of a stiffness or weakness. And the fatigue is also very, very common and often quite profound. And it's commonly also associated with a range of other symptoms that we tend to group them together and call these central sensitizations. And these symptoms are things like brain fog, concentration problem, sleep disturbance. Sometimes we may have anxiety symptoms, and then irritable bowel is also a very, very common features as well. But as I mentioned, this condition is more than just dryness. In about 30% of the patients, they can have systemic involvement. Now, what does that mean? Systemic involvement just means that there are organ involvement outside this moisture-producing glands. So, your system or organ can be the skin, can be your nervous system, in your kidneys, in your lungs, for example. And I've shown on these pictures here some example of sometimes certain type of rash that can be seen in Sjogren's disease. They also can get a peripheral neuropathy, so they get sensory symptoms or tingling. Rarely, it can affect the kidney and causes inflammation there. And then the lung disease is also under-recognized as well, and we probably sometimes see patients with quite progressive scarring type of lung disease in these patients. So when we sort of come back to these moisture producing glands, and there is a medical term called exocrine gland that describe this type of gland. It's really can be actually quite widespread. So it's not just restricted to the T glands and the salivary glands. So Sjogren's disease is by definition an autoimmune exocrinopathy. And these exocrine glands can be found throughout, for example, in your stomach lining, in your airway, in the liver, pancreas. And so we do sometimes see this type of internal organ involvement in some of our Sjogren's patients. So the next sections, I want to move on to the diagnostic challenges that we have with Sjogren's. And this is one of the I guess frustrations in dealing with these conditions, because as I mentioned in the outset, that often people just associate this with dryness, and if the patients are symptomatically very dried, often the treating clinician might be very quick to associate Sjogren's with what they're going through. But we do know that the subjective dryness and the objective dryness actually often doesn't go hand in hand. So some people can be very dried, and when we measure them, there's not a lot of objective dryness. And the same goes the opposite. Sometimes they can be quite objectively dry, but it doesn't trouble them that much. I guess the other aspect of the challenge is that in order to document the dryness that the patient have, often it involves many different types of tests. And a lot of these tests are also not routinely done by rheumatologists. We may have to send you to see the optometrist or the dentist or other specialized imaging studies. So sometimes the diagnosis itself, just to confirm whether someone is dry or not, is not always straightforward. The other diagnostic challenge that we have is that because, as I mentioned about the primary versus secondary Sjogren's issues, that often there are a lot of overlapping symptoms with other conditions. And the most notable one is with lupus. And I've shown you some rash before that Sjogren's patient can get. And actually they can get this rash that are very similar or identical to cutaneous lupus. And often this patient may be misdiagnosed as SLE when they indeed have Sjogren's with a cutaneous lupus rash, but other features to support the Sjogren's too. There are other sort of parameters like the blood count, or that can be low in Sjogren's disease, but it can also be low in lupus. Joint pain is very common in rheumatoid arthritis as well as in lupus. And so these overlapping clinical features can make the diagnosis of the clinician to think about Sjogren's a bit delayed. The other diagnostic challenge is one of the important tests that we can do, which is called a minor salivary gland biopsy or lip biopsy. These tests will review histology, or when we look at the cells under the microscope, can give us quite good idea whether someone's got Sjogren's. And in fact, in the classification criteria, the lip biopsy weighting is as strong as the specific autoantibody that we see. However, the lip biopsy is actually quite difficult to arrange, even where I'm based in Melbourne. It's not an easy test to organize. And when we sometimes eventually organize it, it might be sometimes difficult to actually even have it read properly by the anatomical pathologist because it's so infrequently done. So I think all of this sort of adds to some of the challenges that we have in making a more definitive diagnosis of Sjogren's, and therefore a lot of patients have quite delayed diagnosis. I'll probably come back to the diagnosis part later, but some of the reason for that, for people not making a more robust diagnosis, is that they believe the management is often very symptom-based. So, regardless of whether you have a definite diagnosis of Sjogren's, a lot of the treatments are more about managing the symptoms. So I want to spend a bit of time sort of talking about some of the management approach that we have with the different components. So starting with dry eyes, for example. Again, as I said, sometimes people are more affected and other people are sort of, this is not a big feature for them. And it's also really important to keep in mind that dry eyes is often very multifactorial. So there are more than, even if you have a definite diagnosis of Sjogren's, that there is other factors that sometimes contribute to how you feel. So, for example, some of the pictures that it shows on the bottom there. So Sjogren's disease is when the tear production is diminished. But sometimes as a result of that, patients can have, say, infection of the eyelashes, that's blepharitis, or the meibomian glands. These are little oil glands underneath the eyelashes. They can also be affected as well. So in addition to not producing enough tears and then a lack of this appropriate oil to prevent evaporations of the tear, sometimes the dryness is a combination of all of those factors. There is good evidence to show that if you use artificial tears, it does improve symptoms of dry eyes. However, a lot of patients come to me and say, oh, it doesn't work, or they've tried different ones and they're very frustrated about the lack of response. Most of the most common reasons for that is often not using it frequent enough. So we do ask patients to use it 3 or 4 times a day. And if you've used one eye drops for 3 or 4 times a day and it really makes no difference, then it may be that you need a different type of eye drops. So there are many, many different types of artificial tears around in the market. But the recommendation is to have a good go for at least a month, and then if that is not satisfactory enough, then to move on to other preparations. So as I mentioned, there are so many choices of different eye drops, and it is a lot of trial and error. And sometimes some eye drops, for example, ones with preservative, can, I guess, create another problem if you're sensitive to it. There's a lot of formulations, and some formulations have combination ingredients. And in the study, there's a meta-analysis that actually compare this efficacy of different eye drops, and they do generally find that for combination formulation, they are better in alleviating the dryness symptoms. There's this particular type of formulation called the cationic formulation. So there's a couple of eye drops that are more oil-based rather than aqueous-based, and they have also been shown to be perhaps more effective than the simple aqueous-based preparations. And then, of course, recently we now have reimbursement for immunosuppressants eye drops, so cyclosporin eye drops. And access to these will depend on the optometrist or ophthalmologist evaluations of how severe your dry eye is, despite using regular artificial tears. And so, but in the past, it was very hard to access the cyclosporin eye drops. It was very expensive. But now for a subset of patients who have more severe dry eyes, they now can access that. So I put down at the bottom here to say that not to forget about some simple things. And as I mentioned, the dryness often is very multifactorial. Those meibomian glands underneath the eyelashes, they have little oil secretions that protect the tear film. And sometimes they can become dysfunctional and not producing enough of this gland. And so some of the exercise, like for example, a hot compress or eye massage, they helps to stimulate the meibomian gland function. Sometimes, as I mentioned, that there is infections around the eyelashes and that you might get some crustiness. You can use eye wipes to sort of clean that area. Some of these wipes also contain a little bit of tea tree oil in there as well. And then the other therapy that is talked about probably over the last few decades, but I'm seeing sort of less of that being used, is the punctal plugs. And what this is a little tiny plastic that the ophthalmologist can insert into your drain ducts of the tears. And so if you can imagine, if you're not producing enough tears, then this plug is like plugging the sink so that you can increase the amount of tears that is sitting on your eyes. I see variable response to the punctal plugs, and but some ophthalmologists may offer that to try, and it can certainly be repeated if you have good response to that. And then finally, some ophthalmologists or optometrists can do autologous serum eye drops. So this is a process where you actually donate your blood and they have to send it away and to extract the serum from your blood and then to make them into eye drops. Again, mixed results, but some patients do find that useful. So moving on to dry mouth. Again, is really on top of the dryness, there is other sort of functional aspects. So for example, the type of food that you may choose to eat, or sometimes when in public speaking, that you may find that the dryness can slow you down. And then a lot of patients also talks about this burning mouth syndrome, which a lot of it maybe is contributed by thrush. Thrush is a fungal infection. Sorry, apologize for the misspell there, but it's a fungal infections that can be seen with Sjogren's, and then sometime on top of that they may get ulcers in the mouth as well. So there's a variety of artificial saliva available, and they can be available in the spray form or a gel form. And then we'll also talk about ways to actually stimulate your any residual saliva function by either, for example, sugar-free chewing gum, or just sugar-free candy sometimes is sufficient to sort of stimulate that, like lemon drops and that sort of thing to produce more saliva. We do highlight that you should go for the sugar-free preparation because dental caries is another big complications for Sjogren's patients. There's some newer proprietary preparations. This is xylem melts. Essentially, they are artificial sugar component, but you can tuck this tablet inside your mouth and it can last overnight and alleviate some of the dry mouth overnight as well. And you can use it during the day as well. I talked about getting a dentist involved and really looking out and treat any dental caries, and the value of topical fluoride is probably, I guess, underestimated, and there's a lot of overseas dentists that would recommend more regular topical fluoride when you have your regular review. You can also buy tooth mousse or mouth rinse that contain fluoride, and that you can use that, build that into your normal day-to-day regimes. So finally, just touching on to medical treatment, there are really quite a few different immunosuppressants that we can use. Most of the time, these medications are used when the patient have more systemic involvement. So it's so far this therapy that I've listed here, there is really limited data to show it make much difference to the dryness, but in some patients who have more severe systemic involvement, these are fairly standard immunosuppressants that we use. And this list of medications is not unique to Sjogren's. We use these medications for lupus, we use it in rheumatoid arthritis, and they have different potency depending on what is at risk, which organ is at risk. So there are some emerging therapy or some advanced therapy that we do offer to patients with Sjogren's. So for example, rituximab is a drug that get rid of your B cells, and we have access to that now for many years. And we do sometimes offer that to patients with quite severe disease in Sjogren's as well as other conditions. Sometimes we do plasma exchange, and there are also other off-label treatment. I guess it's exciting to sort of see that there are actually a number of new drugs that are now being tested formally in patients with Sjogren's disease. So I've listed a couple here that, in fact, the top one, lupus-like, has just got an FDA approval in the last 24 hours. So that's very exciting. The next one has the same mechanisms of action and is actually one that is in clinical trial in Australia as well. Ilantamab is another new advanced therapy, and I think a couple of years ago, Monash, where I work, we took part in their phase 2 study, and hopefully we'll be seeing the phase 3 study results soon as well. So in the last couple of minutes, I thought I'll just pick a couple of cases of Sjogren's patients that I had that are more in the sort of severe end of the spectrum, and to really highlight, again, the disease is not just about the dryness. So the first case of Miss S, she's a 45 years old lady who actually presented to hospital with quite severe refractory headache. And in the many workup that she had, she was found to have the autoantibody of anti-Rho, anti-Lyme, anti-Rho 52, and also low neutrophil counts. And these are all fairly classic features of Sjogren's. And when she was initially asked about the dryness, she was quite adamant that she did not have any dryness. And it's not until we refer her on to have that properly assessed that got confirmed. And she was found to have a very rare neurological manifestation called pachymeningitis. And then the next case of a 52-year-old lady who was initially diagnosed with rheumatoid arthritis, and then later on she was told that she has Sjogren's because of her symptoms of dry eyes and dry mouth. And then some years into her illness, her disease took a turn for the worse and had quite severe joint involvement. And on top of that, she also had fevers and vasculitis, which is a skin rash condition. Her parotid gland, her saliva gland becomes swollen, and then she also had lung involvement. So quite a few things happened. She was admitted to hospital for some months, and then eventually the disease was brought under control with a chemotherapy agent called cyclophosphamide. And then the final case that I want to share is Mr. S, who really have had a lot of muscle and joint pain and fatigue for years, but he never sort of paid much attention to it. But about 12 months prior to he saw me, he developed this problem with hemolytic anemia. So his blood count has dropped significantly. And he saw multiple specialists, and they couldn't really pinpoint why this is happening. But he also had quite classic autoantibody profile, and then on hindsight had a parotid enlargement, and so he quite clearly had Sjogren's, but no one recognized that at the beginning of his illness. So I just want to flag, and I know my audience here tonight comes from all over Australia, but we are setting up a Sjogren's registry at Monash in Melbourne, and this is a effort to sort of try to learn more directly from patients about their disease journey and what medication works and what lab test is valuable. And the Sjogren's registry that we're setting up actually model on a South Australian cohort study that has been established for probably a couple of decades now. And so, but collectively, what we want to do is to improve our understanding of Sjogren's disease and to collect information and data from patients to help researchers and healthcare providers to understand the full spectrum of the disease. And we do hope that this is a joint effort together with other sites in Australia, and then also to take part in the international cohort studies as well. And so a couple of flagging to say if you're interested in this, that if you have Sjogren's, it involves coming to Monash for about half an hour. We do ask for some blood that we want to store away, and then annual visits to look for any disease progressions and complications. And then we'll ask you to do some questionnaire about your medical history and symptoms and treatment. So in conclusion, Sjogren's disease is a chronic autoimmune disease that unfortunately remains under-recognized and quite poorly managed because of the attribution to it being only relating to the dryness. And it primarily does affect the exocrine glands. So these are the moisture-producing glands, but it can affect other internal organs and lead to other health issues. There are many self-management tips that I've sort of highlighted, but there is also a range of other health professionals like the optometrist or your dentist who's available to help. And at Monash, we do have the expertise to help and the passion to investigate. And so those of you from Melbourne, if you want to take part in the registry, we definitely welcome that. So I will end here, but with my email address, but I'll see whether there's any question online.
Oh, thanks so much, Alberta, for that presentation. That was, yeah, great, really well presented. A lot of information to digest. So yeah, we really thank you again for your efforts. I guess a couple of questions that we do have. I think one thing that's quite clear is that there's quite a challenging diagnostic process in sort of getting to that final or that formal diagnosis of having this condition. And I guess that can create a bit of, hopelessness if you've gone to your GP with symptoms and they're like, no, just, go see your dentist or, go see the ophthalmologist or the optometrist. So I guess how can we sort of overcome that feeling of, not knowing where to go or not feeling like there's hope to manage what we're going through?
Yeah, no, that's a good question. It's a very common scenario that we hear from patients when they eventually present to us as rheumatologists.
Yes.
So I think at this stage we do we will say to patients that you should try to highlight that you could have these conditions and maybe request a referral to see a rheumatologist. And if you're already seeing the rheumatologist, maybe to prompt them to sort of think whether this is a possibility. Now, in the past, as I said, when there's no definitive disease-specific treatment, often they feel it doesn't matter so much and that they're treating the conditions anyway, maybe for the arthritis or the other problems. And so, and which is true, a lot of our medical treatments are very empirical, meaning it would suit a variety of conditions. But, with now newer therapy coming on, then the diagnosis needs to be a lot more robust for you to access this clinical trial. So it may make more difference now to have that diagnosis clarified.
Yeah, okay, that's great. Thank you. Couple of other questions that we've got here. how much do environmental factors impact Sjogren's and its progression? Is that something to think about as well?
There's not a lot of direct studies, but we do overall are interested in how the environment interact with our immune system. And so I think, the thing that I'm thinking of is one, UV exposure and in sort of making certain skin rash worse. And as I mentioned, the lupus and Sjogren's often overlap. And so
Yes.
that sometimes patients see that connections. The other environmental factors that are sort of emerging, and we haven't really proven it at this stage, is about pollutions and and whether that plays a role in exacerbating increasing autoimmune disease. I think while there's an interest in sort of learning more, I mean, often for the patient who has the conditions, they probably reside in whichever country that they
Yes.
reside in, and there's not a lot of things that they can do to make a difference to that. But I think it will be an interesting area to watch in the future.
Right. Okay, great. Thank you. And do you have any sort of recommendations for, particularly in dry eye symptoms like IPL or red light therapy? That's a question that we've had come up. Do you have any recommendations in that area?
Actually, I don't know enough about red light therapy or laser therapy for dry eyes. I think I'm not aware of good evidence for that.
Yes.
But a lot of there's a lot of I guess gadgets that are used that overall probably just increase heat to the area and it's like acting like a hot compress.
Yes.
So I would probably favor just doing something simple rather than this type of advanced therapy. I don't know enough about that.
Okay. No
Mm.
problem. Thank you.
Mm.
Um, I guess just sort of going back to, we're talking about the diagnostic challenges. We've had one comment come in that's a bit of an issue for this person in Brisbane. Um, her optometrist has flagged Sjogren's, but she's still battling, GPs and specialists. So I guess you're based in Melbourne, but is there any sort of informational places that we can direct people in Queensland, in Brisbane, or in other parts of the country to sort of help them work through that diagnostic process at all?
Yeah, I think a rheumatologist would probably be the main point of contact.
Yes.
And even among rheumatologists, if you ask the people who deal with a lot of autoimmune conditions, they probably be more familiar with the changing landscape in Sjogren's. So, yeah.
Okay, great. Thank you. Um, and then just thinking about the registry that you are working on in Monash, do you need a referral or can we just go to the registry website to sign up for that?
Yeah, we don't yet have a website,
Okay.
so it will require referral from the GP
Yes.
if you're not already a Monash patient.
Okay.
But I'm happy to take emails and direct you. We do have a research fellow who can coordinate the visits and that sort of thing. But
Yep.
yeah.
Excellent. Um, and so does the diagnosis then itself have to come from your rheumatologist, or is it something that your GP can diagnose that you have Sjogren's?
There's a lot of GP who can make a diagnosis of Sjogren's.
Yeah.
But if it comes to advanced therapy, so anything outside those self-management tips that we talked about,
Yes.
you're considering advanced therapy, that's sort of where you would involve a rheumatologist.
Yeah. Okay. And another question that we have here, thanks everybody for sending in your comments and questions. Do you have any diet recommendations for people with Sjogren's to try and reduce those inflammatory responses? Is there any research or anything there that people can look at?
Look, I think there's a couple of ways to answer that question. So I think there's a lot of discussion about anti-inflammatory diet. That's a sort of more Mediterranean-based diet that may overall reduce inflammation in general. And there is no specific study about those diet and Sjogren's progressions, but they're fairly sort of sensible sort of way of eating anyway.
Yeah.
So I think there would be a reasonable thing to try. But in terms of specific to the Sjogren's patients, a lot of the time is really discussion about certain food that may exacerbate their symptoms. And so they may find that sometimes softer food or food with gravies would be easier for them to consume. And so a lot of the time patients actually figured it out themselves what food they can have and they can't have.
Yeah, that's great. Thank you. And I guess because it is quite complex and, a lot of factors involved in managing the condition, are there any good resources or websites that you would point people to sort of help build their knowledge and self-management to sort of empower patients or consumers as they're sort of progressing in this journey?
Yeah, so well, MSK
Yes,
Australia, you might have some useful website.
we do.
And so please check that out. I am involved with the Australian collaborators and whatnot, and so I think we are thinking that it's time to set up a Sjogren specific patient organizations. But otherwise, you'll find that there are other patient organizations that have interest in immune conditions like lupus, that they would touch on topics that covers Sjogren's as well.
Yeah.
Yeah.
Okay, great. And I guess I'm just having a look through. There's another question here. Do you have any thoughts or feedback on what the sort of currently most promising drugs are that are in development or under research or clinical trials? Somebody has written, what about Dazodalibep? Not sure if
Yeah,
I've pronounced that
that's
properly.
a anti-CD40 ligand study that had some really nice results that was presented earlier in the year. And so, yeah, I think we're actually quite lucky from having no clinical trials at all for Sjogren's patients to now probably worldwide. I think the last I count, maybe 10, 13 different study happening.
Yes.
So I'm certain that in a few years we will hopefully get a newer therapy. But right now, in order to get access to these, I think you will have to go through a rheumatology department and see what trial they're actually recruiting for.
Yes.
So I think in terms of access by the general community at the moment is probably still at least a few years away.
Okay, yeah. And so that was the next question about if somebody did want to sort of be, participate in the trials that are happening in Australia, is it best to sort of work with their rheumatologist to get referred to
Yes,
those?
yes.
Yeah, okay, great. Well, I'm just having a quick look through the questions here. And we're almost coming up to end of time. So I think actually we might wrap it up there, Alberta, unless you've got any other comments or feedback that you wanted to leave the audience with.
No, it's been a lovely experience, and yes, I really do hope that we can learn more about the disease and have more treatment available for the patients very soon.
Yes, we feel the same. So yeah, thank you again very much for coming on board tonight and presenting the information. And as I said earlier, we will have a recording available. Thank you to everybody who sent through your questions. Hopefully we've been able to cover those off for you, but Alberta has got her email address there as well. Or, please feel free to visit our website. We do have information on the condition as well available for people to look at, or even get in contact with us on our helpline as well to, find out more. So yeah, thank you again, Alberta. Really appreciate it. Thanks to everybody for your support, and yeah, have a good evening, and we will see you at the next webinar. Thank you so much.
Bye.